Welcome to another presentation by My Weight World. The topic of this presentation is the vertical banded gastroplasty surgical procedure. This presentation is designed to give you a brief overview on the topic of vertical banded gastroplasty surgery. Let's discuss who is a candidate for weight loss surgery. A typical candidate failed many attempts at dieting, is morbidly obese, i.e., they have a BMI of greater than 35 with 1 to 2 strong comorbidities, or a BMI of over 40. Let's look at surgery versus medical therapy. Medical therapy for morbid obesity does not work for most people long-term. Long-term is your entire life. So, despite good intentions with diet, exercise, and/or medications, medical therapy usually fails. For these people, surgery is an option. This slide is talking about someone who is morbidly obese, not someone with a minor weight problem. Weight loss surgery has been around for more than 50 years. The first weight loss operation was in 1954. It was called intestinal bypass. It is no longer being performed. From 1954 to the present, there has been significant advancement in weight loss surgeries. There are a number of good operations to choose from. There are many different types of weight loss surgery. Here is a list of the top 5 used today throughout the world. Gastric banding, biliopancreatic diversion with duodenal switch, intragastric balloon, gastric bypass, and the vertical banded gastroplasty, VBG. The remainder of this presentation will be about the VBG. Let's discuss the normal anatomy of the stomach and intestine. Food goes into your mouth and down the esophagus, which is your eating tube. The food then goes into your stomach, where it is grinded up into smaller particles. No calories are absorbed in the stomach. The small food particles then travel down to the small intestine, which is approximately 20 feet long, and here is where the food is converted into calories and absorbed. From there, the remainder of the particles travel down to the large intestine, where most of the liquids are absorbed, which causes a solid stool. No calorie absorption is performed here. The stomach is shaped like a backward C. Its primary function is to grind food for food digestion. The food then enters the small intestine, which absorbs the food calories. The stomach does not absorb calories. Procedure. The VBG is a fairly simple procedure. The stomach, which is the size of a football, is reduced by a plastic band and a staple line to the size of a golf ball or half a cup. This is called the pouch. This limits the amount of food you can ingest and deliver to the intestine. Modern versus older method. If contemplating a VBG, there is a technical difference between the modern and the older method that you should know and you should quiz your surgeon about. In the older method, a staple line is performed, noted by the arrow, without any separation. The modern method has a separation between the two staple lines. In the older method, without the separation, there was a chance that a connection could be made between point A and point B. This connection is called a fistula. If a connection occurs, food could travel not just down the regular route, but also through the fistula. In the modern method, due to the separation, a fistula could not occur. This is why the modern method is recommended over the older method. Mechanics of weight loss. The VBG has one weight loss component, reduces the size of the stomach pouch. This golf ball-sized pouch limits the amount of food you can ingest. History. The VBG was the first major restrictive weight loss operation. It restricted the amount of food you could eat with the pouch. The VBG was the most common weight loss operation in the U.S. until the mid-1990s. It fell out of favor due to a better and more sustained weight loss by the gastric bypass, There are similar weight loss but more potential complications with the VBG than a gastric band, for example the lap band, and there is a significant number of patients who regained a good portion of their weight back by stretching their pouch. Here are the pluses and minuses of a VBG. The advantages are, the VBG is completely reversible. Your body anatomy is left intact, no body parts cut out. There is no dumping syndrome, which can occur with the gastric bypass, and there is no nutritional deficiencies, especially with a proper diet. The disadvantages are, the VBG needs a strict patient compliance to diet. There is no malabsorption weight loss component that you can see with the gastric bypass. See website for more on gastric bypass. Vomiting can occur if food is not properly chewed or if food is eaten too quickly. Many people, not all, can regain a large portion of their weight back. Pouch stretches. Let's look at the predicted weight loss of the VBG. To do so, first we must find excess weight, which is existing weight minus your ideal body weight for your height and sex. For example, if you are a 5 foot 4 inch female with a present weight of 335 pounds, the ideal body weight for a 5 foot 4 inch female is 135 pounds. The excess weight is the difference between the two, which is 200 pounds. The predicted average weight loss after a VBG procedure by most U.S. surgeons is between 45% and 50%. So, the predicted weight loss for this woman is 90 to 100 pounds. This graphic gives you an idea of the pattern of weight loss with the VBG compared to the gastric bypass. The VBG is represented by the green line, the gastric bypass by the purple line. Typically, with the VBG, the patient will see the majority of their weight loss is in the first year, and some subsequent weight the second year. From here, the weight loss will taper off. Ideally, if they follow the diet program given to them by their physician, they will maintain their weight loss. Typically, weight loss from the VBG is between 45% and 50%. The complication rate for the VBG is between 1 and 5%. This includes both major and minor complications. Major complications include blood clot to the lung or a hole in the stomach requiring surgical repair. Minor complications include urinary infection, pneumonia, and a small incisional infection. The average mortality rate of a VBG is between 1 out of 1,000 and 1 out of 500. This is a typical quoted rate for a VBG procedure. Results will vary from one surgeon or program to another. Summary. The vertical banded gastroplasty is not used commonly in the U.S. anymore. This is because weight loss is inferior to the gastric bypass. Weight loss may be similar to gastric banding procedures, but with a higher complication rate. Many people have regained a significant amount of their weight that they lost due to stretching of their pouch over time. Weight loss from the VBG is for one reason. It causes a small stomach constricted by the band. The average loss of excess weight 45 to 50%. The average low death and complication rate. There are other presentations on other weight loss surgical procedures on myweightworld.com. Please see those. This has been another presentation by My Weight World.